Hi, I'm Kelly Limboy from Arthritis Consumer Experts. And on this episode of Facts Friday, we're pleased to welcome Dr. Carter Thorne, Assistant Professor of Medicine, University of Toronto, and Chief Division of Rheumatology at Southlake Regional Health Centre in Newmarket, Ontario. Dr. Thorne, thanks for joining us.
Thank you so much, Kelly. And I want to thank you and congratulate both you and Cheryl on this fabulous idea of bringing information, help, compassion into the homes of people who have arthritis.
It's really, I think, us who should be thanking you, Dr. Thorne, because one of the things we want to talk to you today about is the work that you're doing as one of the leaders of the Canadian Rheumatology Association, where you've been actively consulting with Health Canada, public drug plans, pharmaceutical companies about the drug shortages affecting patients with autoimmune disease as a result of the COVID-19 pandemic. Can you explain to our audience, many of whom have contacted us here at ACE, about recent challenges they've had to access hydroxychloroquine, or HCQ, what's going on with our drug supply, and who potentially is at risk?
This was a pan-Canadian issue about drug supply. And what we've learned is that medications like Plaquenil, hydroxychloroquine, and chloroquine that preceded it have been considered to be repurposed. Maybe it'll have some antiviral effects. Maybe not surprising because these were antimalarials. Who would have thought they would help with diseases like rheumatoid arthritis and lupus? The original study from France was very small and subsequently has been demonstrated to be not of good caliber. But notwithstanding, one can imagine that in the face of a disorder such as COVID-19, where there is no specific therapy, that people are going to reach for something. So Plaquenil became an important part of that, also called hydroxychloroquine. And in the run-up to it, because this has spread over the globe in a piecemeal fashion, what was learned in one continent is then transferred to another continent for possible verification. So it turned out that as we started accumulating numbers, remember, it happened very quickly and unexpectedly. We thought this would be like N1H1 that would come and go, but it came and stayed. That all of a sudden, the supply in the marketplace was used up. It wasn't actually used up, it was bought up or accessed. It turns out it wasn't patients accessing it. It was actually hospitals accessing it, trying to increase their inventory, because most hospitals won't have an inventory of Plaquenil because it's an outpatient medication. So our patients were finding that they couldn't access it because the shelf was bare. Now we know that there are about 85,000 patients in Canada who regularly use Plaquenil or hydroxychloroquine for diseases such as rheumatoid arthritis, lupus, Sjogren's, other connective tissue diseases. It's a very effective medication in people who have mild to moderate disease. And it's very effective over the long time. It has one of the least burdens to the patient in terms of taking it. But it was suddenly taken out of the market. Not taken out of the market, it was accessed by hospitals. And this was quite regional. It did not happen in all provinces. So there seemed to be a significant uptake or loss in Quebec because there is apparently more demand. We don't know the regional space there. We were also aware that the number of manufacturers, the people who actually supplied the product, had diminished over time. So that though there were nominally 5 manufacturers, there was only 3 that were quite active, and there was, and 2 of them had a significant market share. It was probably regional variation. Because this happened, Health Canada has a process where they look for drug shortages. And right now we do know, and we've heard from the Pharmacists Association, that whereas this is a really remarkable number, on average, 10 medications go on shortages each week in Canada. Now it's 15. So there's numbers of medications that are going on shortage. In this regard, because of the significant shortage in Quebec, Health Canada determined that there would be a shortage. The good news, and as you pointed out, I've had the opportunity to work with Health Canada in the drug shortages group. We heard earlier in the latter part of March that this was going to be resolved. and consistent with the positions of Canadian regulatory authorities, professional bodies like the Pharmacists Association, the Rheumatology Association, the colleges, that most of these were recommending that products of a legacy nature, like Plaquenil, should be reserved for patients who had these diseases. And indeed, by the time we had our engagement with the minister, with Health Canada at the latter part of March, we heard that indeed the inventory had gone up. So in the majority of Canada, except Quebec, this shortage was very much of a blip, 1 or 2 weeks, where pharmacies were scrambling to ensure. Some of that mitigation or prevention strategy in some of the larger provinces have been by restricting the number of medications you can receive usually. So in my practice, we'll give people a 3-month supply or a 4-month, depending if they're traveling. Now you can only get a month. I want to remind your viewers, this is for all medications. So the burden in the population is now you have to go to your pharmacy 12 times a year instead of 3 or 4 times a year. You're paying a different dispensing fee. We have made the ministries aware of this. They are aware, and they believe that this 1-month supply only will be of a temporary nature. We are aware from our colleagues in Quebec, and you and I both participated in a teleconference earlier this week, where I was shocked to hear that our Quebec colleagues were still experiencing a shortage. That was completely unexpected, because we know that some of the major companies, and indeed some companies that aren't even in the market with this product, have come forward. And there are now millions of doses, literally millions of doses made available for studies. In Quebec, they still have a distribution problem. We are having I'm participating in another meeting tomorrow with Health Canada talking about this very specific issue. So our listeners should be very confident that in all provinces and territories, that Plaquenil is available, it has been distributed, and for whatever reason, there's a disparity in Quebec. It seems to be a distribution problem.
Yeah, and I think that's the key for our viewers, is to understand that it is a distribution problem now. It's not a supply problem. Just as one follow-up, Dr. Thorne, some of those patients that you've described who have been successfully being treated by hydroxychloroquine over the years of their disease, to control their disease, because they are hearing things in the media, because they are hearing information that's coming from across the border, they have these concerns now about the side effects, about how this drug is so powerful, that there are these risks that patients should be considering if they're going to take it. What is your guidance for our patients viewing today?
I personally have been using hydroxychloroquine for 40 years. And I inform people who I think required or will benefit from it, that this is the least burdensome medication. You can take it with or without food once or twice a day. You can take it with other medications in general. And in general, we can usually reduce the medication. And if we follow guidelines based on height and weight, the issues related to ocular toxicity, eye involvement are very much minimized. But here's the trick that's the issue. As you mentioned, we're hearing a lot about the side effect profile, particularly the issue related to heart problems. Now, in the setting of COVID, even though we think of this as a super flu, it is a disease that not only damages the structure of the lungs, but also involves the heart. And the heart is an electrical organ. And when we start talking about people who have structural abnormalities, we are not talking about our patients. So in the setting of COVID, where they are giving doses that are not seen by patients who have lupus, rheumatoid arthritis, etc., they are seeing issues related to conduction abnormalities. Whether that relates to the inflammation of the heart as part of the disease or not, we don't know. However, I think our patients can be reassured by over 40 years of constant use, in which people of all ages get the medications and with multiple comorbidities, that we do not have patients with these kinds of issues. at our center in Newmarket, we have a very high-end electrophysiology department in our cardiology group. These guys are top-notch. UHN, TGH refers some of their patients to our hospital for pacemaker and ablations. And I asked our lead guy here about this. He says, this is not a real problem in the real world. In the population that we are dealing with, this is not a problem. So it becomes important that a person who's using this medication has experience with it, knows that there is no cumulative toxicity in the heart or the lungs associated with this product. We do have to be careful in dosing related to ocular involvement, but this is not something that comes on in the 2 weeks or 2 months as you might hear in the media. The other precedent that our members, that our listeners have, is that oftentimes they'll go to the pharmacy with medications such as methotrexate and hear that anti-inflammatories are detrimental, and that taking a proton pump inhibitor are detrimental. That's in a completely different population, but the pharmacist is still obligated to tell them about it because it's on the profile, but has no relevance to them. So members who are using Plaquenil have had experience with it, have been taking it for days, weeks, months, years, and sometimes decades, should feel reassured and comfortable. Make sure that you understand that this medication does not interfere with your immune system. We have no idea whether it's protective of COVID-19, but you should be reassured that taking it minimally at the minimum doses that's required as per your rheumatologist is a safe and effective medication.
And it seems to me an underlying message here, just to go beyond HCQ, is that during this pandemic, whether or not they are on a biologic, a targeted small molecule, an anti-inflammatory drug, I think what I'm hearing from you is that those patients should continue to be taking their medication and not considering stopping.
Yeah. I think some of the challenges that we are facing, Kelly, is that people making these pronouncements have little experience with the medication. They just read the monograph and say, oh my God, this is going to be a problem, as opposed to asking the advice. So we do know, again, because we talk about our medications in an autoimmune disease as immune modifiers, it sounds like you're immunocompromised. Indeed, we know from past experience, again, COVID-19 is pretty new, but there's been no evidence to date that patients who have rheumatoid arthritis, as you mentioned, on NSAIDs, traditional or legacy, conventional disease-modifying agents, the newer synthetic targeted agents, nor the biologic agents, the injectables and infusion medications, that these are related to excess issues. The guidelines for use or withholding are the same as if you had a bad bacterial pneumonia, a bad infection in your gut, a bad infection in your leg, is to withhold for those periods of time. But in terms of increasing risk of becoming infected, that is not the case. The biggest risk for getting infected is being exposed, because this medication, this virus is very easily transmissible. So that's why we have this kind of process that we're having here, where we're talking over the screen. Our computers can get viruses, but they can't share it with us. And I think the important thing for our members to know is the physical distancing, being careful. If someone you know and love has been infected, be careful. If someone has traveled, be careful. And follow the instructions of your public health leaders in your region, in your province, in your town.
I guess one final question, Dr. Thorne, is we are getting asked now if there are other arthritis drugs that are being explored or considered as potential treatments for COVID-19.
So again, because as many people have heard, and I think our patients that you deal with, because they're really becoming highly educated because of your efforts, is that they're aware that we have immune diseases, and they probably heard of this cytokine storm, and that the biologic agents are by and large anti-cytokines. So in this instance, they're trying medications that have been identified that help the cytokine storm that appears to be associated with these disorders. It is important to realize that neither medications like Plaquenil or antiviral agents for which there have been uses, for instance, treating HIV/AIDS or some of the other viral agents, I should say, as well as the biologic agents have been tried, but none have been demonstrated to be effective. These are all what we call hypotheses. It sounds like it might work. If we're going to try something, it's easier to try something that is known than unknown while we're waiting for the vaccination that will protect us all. And it's like I remind my patients every October, November, December, get your flu shot.
Yeah.
Hopefully we're going to be able to say, get your flu shot and your COVID shot for the next cycle. And your members here should be also getting their pneumonia shots, should also be getting their shingles shots, should be making sure they're boosters. Vaccinations will make a difference. Until we have a vaccinations, we're trying to find agents that'll make a difference, that will help patients who are unfortunately exposed to the virus. And remember, 85% don't really have a bad illness, but the 15% of a large number are getting sick. And the question is, when can these medications be most effective? And when a patient has been in the ICU for a month on a ventilator, probably none of these products are going to be effective. And like how you manage a person with rheumatoid arthritis in different diseases, stages of their illness, early disease, middle disease, late disease, very active disease, mild or moderate, that's part of the art of the care. And we're learning from that. But remember that right now, we don't have true knowledge. We only have empiric trials.
On behalf of arthritis patients across Canada, we want to thank you for all of your efforts and your leadership, truly making a difference, and we greatly appreciate it.
Okay. And as you said, Kelly, stay safe, stay healthy, keep your distance.
I think that's a great way to end the program. Thank you again, and join us again next week for Motivation Mondays.